agenda this morning in terms of 3 main items that we're going to talk, so we'll work to roughly 20 minutes per item in my head. So let's start the recording. Good morning, welcome to the Health and Wellbeing Board for the 11th of January 2024. I'm in the chair today in Councillor Elcher-Wellington's absence. What we'll do this morning, we'll go round and do introductions, and then we'll do apologies, and we'll go from there. So, don't know where we want to start. Let's start over there.
Councillor Liz Simpson for New Biggin.
Thank you.
Abby Conway, Chief Executive Citizens Advice, representing the voluntary sector through Thriving Together.
Good morning, Jeff Watson, a Cabinet Member for Healthy Lives.
Good morning, Hilary Snowden, Executive Officer for Northumberland LMC, Local Medical Committee.
Anne Everton, Pharmacy Advisor to the Public Health Team. Debbie Nugent, Health Watch Northumberland for Peter Stanfield, who may be a bit late.
Good morning, everybody. I'm Steve Kennedy, Assistant Chief Fire Officer at Northumberland Fire and Rescue Service, and I'm here on behalf of Graham Binnon.
Good morning.
Hi everyone, Lynn Patterson, Deputy Director of Northumberland Place, ICB.
Neil Bradley, Executive Director for Adults at the Council.
Good morning everybody, I'm Superintendent Kevin Waring and I'm here on behalf of Chief Superintendent Sam Renison.
Good morning, Sheree McCartney, Group Nurse Director for CNTW Mental Health Trust.
Good morning, I'm Wendy Patterson. I'm the County Councillor for the Long Houghton Division and Portfolio Holder for Caring for Adults.
Good morning, Kenny. I'm Senior Primary Care Commissioner Manager for North East North Cumbria.
Good morning, I'm Pamela Phelps. I'm the Deputy Director for Primary Care across North East North Cumbria, ICB.
Good morning, Graham Writer, Director of Children's Social Care at the Council.
Good morning, Rachel Jones.
Morning everyone, I'm John Mulder, Public Health Consultant at the Northumberland County Council.
And I'm Leanne, also Public Health Consultant here at the Council.
Hi, I'm Luke, I'm Public Health Registrar at the Northumberland County Council.
Good morning.
Hello, I'm Anne Lawson, I'm Public Health Manager at Northumberland County Council.
Hello, Rob Murphy, Director of Housing and Planning at the County Council.
I'm Leslie Bennett from Democratic Services.
And I'm Graham Syers. I didn't introduce myself properly at the beginning. I'm a clinical lead at ICB NENC.
Good morning, Colin Horncastle, Cabinet Member looking after our communities.
Veronica Jones, Cabinet Member for Public Health, improving public health.
Morning and Happy New Year. Jill O'Neill, Exec Director Public Health for the Council.
Thank you. And do we have apologies?
Yes, apologies from Graham Binning, Paul Escher-Shelvin, Victoria McFarlane-Reid, Guy Renner-Thompson, Sam Renison, Christine Wardlaw.
Thank you. So we'll move to item 2, which is minutes of the previous meeting. Has everybody received them? We had a small matter of type that Leslie was given from Peter, but otherwise are we happy with the accuracy, and can we accept them please? Thank you. Disclosures of interest. Peter Sansfield has mentioned that he is an exec for Abbeyfield Care, and therefore item 4 on the agenda, he just wanted to declare that interest in terms of housing. We've considered that, and actually it's a public meeting and we're not making any specific decisions with regard to that, so if he does arrive late, we've accepted that he can take part in the meeting. Would anybody else like to declare any conflicts of interest? No? Okay, thank you. So that moves us to item 4, which is the Healthy Neighbourhoods paper, and I'm going to pass to Councillor Horncastle and Councillor Jones to introduce this paper. Thank you.
Thank you. It is a joint paper, so you'll hear from both of us. So this report's about creating healthy neighbourhoods, and it's a joint report, as Graham said, from Housing and Public Health. So last month we had the refresh of the Health and Wellbeing Board strategy on what was we call the wider determinants of health, or the building blocks of a healthy life. So that came here last month. One of the priorities, you may remember, was providing healthy neighbourhoods, was identified as a priority. So healthy neighbourhoods is very broad, and again, within that, there was 4 separate priorities. This, the first one, focuses on supporting housing through the planning process, working with public health to provide a good building block, or rather, a building block of a good life. Others will include the Blythe Deep Dive Housing Hub, the Hurst Master Plan, and available affordable quality housing. So we're linked with the Northumberland Inequalities Plan to improve living conditions and reduce the gaps in our communities. We are one of the largest social housing landlords in the county, so it's an opportunity for us to lead by example for the development of high quality housing schemes. So there's 3 questions. I've got these written down. 3 questions for consideration. It says 3. I've only got 2. How can the member organisations of the Health and Wellbeing Board help the development of a housing strategy which priorities healthy outcomes for our residents? And should the planning and public health teams take the full health impact assessment presented as part of the planning process for consideration to the Health and Wellbeing Board? And the third one, what more can we do to become an exemplary in the development and delivery of housing within Northumberland? Colin's going to talk more about housing, so I'll just pass over.
Thanks, Veronica. Yeah, I suppose this is like stepping out of the past into the future. If you think about the way local authorities have worked in the past, you had different departments. You had, let's say, planning, housing, highways, finance, whatever. And they all did the job and they all worked very well. But how many times have you heard people say, or you've said yourselves, do they not talk to each other? And this is exactly what this is about. So I'm looking at this from a planning point of view. Now, basic planning, I'm sure Rob will have something to say about this, but basic plan in the past has been, plan application comes in, if it meets, basically how it works is if it meets the policy and various conditions, it's accepted and passed. But there's very little thought actually went into what came out of that plan application into new housing estates and developments in various places. And as things progressed, we started to think a bit more about design. But design was basically materials and what the actual housings and the housing estate looked like. But we've got to move on from that, and we've got to consider the implications of these large plan applications and these new housing estates. What can we do to actually make people who end up living in these houses, either rental or buy them, what can we do to make their experience, their life experience, actually feel better so that they themselves are happier in that environment? So we've got to look at, we've got to design out crime, we've got to make it easier for various services to have access to these places. We've got to look at all the different things like play areas properly, green spaces, all these sorts of things, give people a better experience, a better living experience, and that's what this is about. So, can we make it work? Yes, I'm sure we can make it work, and it's a new concept. But if you look at other various departments in the council, I mean, prime example is the Fire and Rescue Service, how they've integrated into all the different departments in the council. So there's no reason at all why the planning side of things can't get involved in this and make it a better life experience for people.
Thank you. So I think we're going to come to Anne now, aren't we? Is that right? Or Rob first?
Thanks for those 2 introductions. This area of work is a real challenge, and I want to make that point clear up front. Okay. Yes, in the past, government has charged us, in terms of planning and housing, with basically delivery of numbers. Okay. And we do refuse applications for things like flood risk, etc., and design. But the real challenge to us all is that's been on a test of adequacy. In other words, are things bad enough to refuse? Okay. The challenge I'm going to put forward for you today is about, and it's about true partnership working here, about getting schemes that are good enough to approve. And by good enough, we've done a lot of work now on the Health and Wellbeing Board, and we have various strategies on saying what we want to achieve. This is about putting it into practice. Okay, just a few marks I want to put down before I bring Anne in. Okay. When we talk about health inequality on a place base, many people think about an inequality in terms of access to services, to healthcare facilities. But ill health expresses itself in different places as the most clear pattern of inequality. Okay? And so it's obvious that it isn't just individuals, but it's how individuals react to where they were born, where they grow up, and where they live. So, you know, good quality homes, robust places are fundamental components of a healthy life, but not on a straight causal basis. It's also got a almost, you know, what I always say is when you look at the other great measure from my perspective of health, and that's getting people into active employment, it's really clear that endemic poor health or poor health living conditions cause low economic activity. But equally, low economic activity causes endemic poor health. Okay, so what we're looking at here in this paper is we know the arguments. It depresses me slightly that these arguments were picked up. Let's wind the clock back, because planning and public health shared a common point of origin in the 19th century when we were looking at the slums in England and things like cholera outbreaks. Okay, we have known what we've got to do for a very long time, and this is about putting into practice. So what this paper and this approach we're talking about today in the questions is, are we up for the fight, really? And are we up for tackling this with the seriousness it deserves? And how actually are we going to translate the noble aspirations we all share as an abstract into actual decisions? In other words, when it comes to push comes to shove, are we going to say no to housing quality that we do not feel is good enough? And the questions that have been posed are only part of that, in that, you know, we've got to be prepared to lead by example as well, because we are the biggest social housing provider in the county, and we may have to do that thing of chasing the numbers of new houses and perhaps focus more on the existing quality of what we've got already. And before I use all the time up, we often also talk about getting existing housing up to being good quality, up to modern standards, retrofitting. My problem is, if we're not careful, we are building houses this week that we know need retrofitting to meet modern standards. Anne.
Thanks. So, thank you. Thanks for the great introductions from Veronica and Colin and Rob. Veronica introduced the questions, so I'm not going to go through those again. There are some great opportunities in this situation. As Rob has outlined, we've got an opportunity to really change the way that we do things. Some of the things that we have thought about are in Northumberland, change the way we write the housing strategy every year, so that we underpin the housing strategy entirely through health, and we're going to start working on a collaborative version of that with the support of public health in the housing team. We can prioritise healthy housing initiatives through maybe getting a group of you together as a housing forum, a healthy housing forum from the Wellbeing Board to feed into that and the decisions that we make. We ought to, as Rob said, lead by example and the delivery and development as organisations collectively around the table of high quality housing schemes, so that we can say to other developers that come into the county, this is what we expect you to be, the standard that we expect you to be meeting. Design codes are a new thing coming in through the Levelling Up and Regeneration Act, which will allow us to enforce some of the planning decisions that Rob's alluded to, that we need to be able to make to bring up the healthy standards of the properties that are coming into to being. We can work with the North East Mayoral Combined Authority and developers in the region, not just the county, to get a consistent messaging around healthy schemes for the whole region. So the developers know that the region is open for healthy schemes. And as Veronica said, think about whether we should be bringing some of the full health impact assessments that we receive as part of planning applications, bring them to you and let you have a look at them and comment on them before we respond. So those are some of the opportunities. We have some considerations. As Veronica said, we've got nearly 8,500 properties as a local authority. We need to get those properties to the standard that we expect everybody else to be building to, and that requires some investment. Integrated care strategy and health fairer programme has also got addressing wider determinants of health as a priority. So it's not just the county council, it's us as a partnership. We know through using the place standard that resident voice tells us that communities don't have access to suitable, affordable housing all the time. So we need to look at that. And also there is an issue potentially around private rented sector where there is underreporting of the conditions that people are living in some of those houses. As Veronica has said, we've already taken housing and planning as building blocks of a good life through the Health and Wellbeing Board in the strategy refresh, so I won't go through that. There are some good frameworks that help us to think about the breadth of getting a healthy home principle in place. Town and County Planning Association has one that explains that fire safety, livable space, access to natural light, reduction in carbon emissions, climate resilient. There's a raft of elements that make a place healthy that we need to consider. And the National Design Guide that came out a couple of years ago talks about a well-designed place, which is not just about the house, it's about the environment and the various elements that sit around that. Again, we need to think about all of those things when we're creating new places for people to live. We've started to roll out the use of the place standard tool in terms of engaging and having conversations with our communities to understand how people feel about the place that they live in. The chart on the screen there shows you 3 of the places that we've spoken to, people in the Hurst, people in Bedlington, people in Cramlington, about how they feel. And you can see that the star shows you how they feel about housing, and that changes. So the blue line, the outside line, is Cramlington, the one in the middle is Bedlington, and the one nearest to the centre is Hurst. So you can tell that people feel differently in terms of scoring. We also have a lot of qualitative information about how they feel about where they live in those places too. And as time goes on and we talk to more people in more places, we'll have more evidence, both quantitatively and qualitatively, about how they feel. So the things we hope to do, firstly, talking about housing. We want to retain a focus on warm homes and fuel poverty. We all know that that's important. We want to keep people in their own homes for longer and have strategies for that. We want to underpin all of that with climate change and low carbon initiatives. We want to think about affordable housing, do an affordable housing needs assessment across the county, think about rural affordable housing. We want to be an exemplar as the biggest social landlord in the county, and we want to drive up quality. We want to have a housing and health conference towards the end of this year, underpinned by the new housing strategy, which is focusing on health, and we want to include in that social landlords, private landlords, housing developers, elected members and partners from round the room. We want to deliver, we know we have to deliver additional homes for Northumberland, so we need to be an exemplar in that, both as a planning authority and as a landlord. And we want to work with all partners to get to that point. We'd like to think about a health and housing forum which involves interested parties around the table to participate in the discussion as we develop all of those things, as we develop the healthy housing strategy, and we'd be interested in thinking through who might be involved in that. The housing service is going to restructure slightly so that we can have a new strategic function. We can lead on health strategies and make sure that this actually follows through in terms of delivery in the housing team. In terms of planning, We have a raft of tools open to us in terms of enforcement and encouragement to others to get involved. We're now working with health impact assessments and receiving those for the bigger schemes, and we can comment on those and give feedback. We've got the opportunity to get a common narrative across the combined authority. We'll start to work with developers and let them know what we're looking for before they start designing schemes. Public health want to be involved in all of that and provide support, not just be a sort of bystander to that whole process. We want to continue our engagement with communities to understand what communities want and need. And we understand that sometimes the supporting infrastructure is a challenge. GP, dentistry, school availability, it sometimes can be a challenge. So we need to think about how we support with that. We've got healthy design codes as an opportunity to underpin the enforcement, and we can do benchmarking. We're talking to other local authorities about how they do this well. And there's also national policy, which we will continue to be across and respond to guidance. And we hope to help shape future policy, so we're talking to some of the policy makers in this field as well. I'm going to hand you back to Rob now for a discussion on the questions that we posed in the paper.
There's 3 questions posited there in terms of how the members of the Health and Wellbeing Board can help the housing strategy, your role in health impact assessments, and how it can become more of an exemplar. I want to put this a bit more clearly. Right. Without sounding like I'm asking for a 2,000-word essay for university, this is absolutely an example of partnership working. Okay. None of you in this room are, say, examples on flood risk modelling. But equally, though, we need to hear your voices when we do things like the design of housing, both its location and its form. So the question is, how you see best getting your agendas individually understood by a group, and Anne mentioned perhaps a healthy housing forum, a subgroup of this group. Because I don't want this just to be a nodding and that's nice to have. Because the risk is, because planning is charged with delivering housing numbers, then tackling climate change, flood risk, affordability, rural diversification, improving the environment in terms of ecology, highways, etc. I don't want this just to be another voice which becomes an inconvenience. So it's a case of how there can be empathy between ourselves in terms of our different agendas and actually see some real change in it. Okay. So with that, this is an open question. It's about how you see your roles, which perhaps haven't been traditionally involved in directing position into planning decisions, how you see that best working. And those 3 questions are meant to be a prompt. Thank you.
Thanks, Rob. And thank you for the presentation. Yeah, it's quite a lot of information in there. And I think it's a challenge for members, perhaps, who've not really gone outside their organisations to think about planning and housing, to actually start to think, well, who would be responsible in my organisation to have a role in that, or how do we do it, or how relevant is my organisation? So I'm just going to open it to the floor to see what thoughts people have. And if you've got some specific answers to those questions in your head already, tell us. Who wants to go first? I saw Kevin nodding. Sorry, Kev.
Yeah, no, thank you. I mean, just going back to the point, I think Colin, you highlighted, it is Colin, isn't it? Yeah, brilliant, thank you. The closer and the good example of the working you've got with the fire service embedded within the council at the minute. We're really keen to be thought of like that. And as an organisation, we're moving to 6 area commands, and we're going to be very much focused and aligned to Northumberland Council. We're also working to see how we could better integrate with Northumberland Council and be able to be available to contribute on a more regular basis around all matters that you just highlighted across there. Designing out crime is one of the critical bits for police, and that can contribute to that. And you've highlighted, I'm asking myself, well, who in the police currently contributes to any planning decisions around, new estates in terms of designing out crime? Are you able to tell me who that is at the minute, or does it happen?
we have a list of statutory consultees who we consult, and we consult the police on an organisation basis. We have an email contact which we send consultations to. At the moment, we only tend to do that where there's been sort of a request from either a resident or a parish or town councillor where there's a perception there could be a crime issue associated with it. For example, if we got an application for, say, a new nightclub, we would consult the police. What this is getting at, I suppose, is the starting point for design to what issues the police would want to be thought about. Right. So we're not talking in abstracts, right? Okay, I'll give you one example, and I see this one playing out a lot. When you are designing a new housing estate, say one of a modest scale, say 50 houses, our hat that says walking and cycling and accessibility tends to put in loads of footpaths, links, what we call permeability, around the edge of the site, linking it to parks and to nearby streets. But those, I don't know what they're called in the northeast, these were called ginnels in South Yorkshire. But footpaths between houses are really important for promoting active lifestyles. But actually we get loads of complaints because that's where it's perceived that youth congregates and gets up to mischief. So there's a tension there, and it's also been able to dispel some of the myths that certain designs will either encourage crime or won't. So perhaps we need to have a conversation offline about how actually we want to draw on your skills here. Because I keep coming back to this point, and this is an invitation to you all. This is a genuine attempt to hear the voices which have traditionally been underheard in the design process, okay? Because I can't put it better than, as a group like this, we will regard these as nice to have sometimes, but they're not their fundamentals. It's how we actually make this a mainstream point. Yeah.
Okay, thank you. I've got Neil and then Abby and then Jeff's put his hand up.
Yeah, thanks, Graham. Yeah, just from my perspective, I think what I'm observing in terms of the door opening here around Health and Wellbeing Board being able to have a greater input into housing development and housing strategy is we're at very different starting points in different areas. I mean, certainly from an adult care perspective, which is my primary role, I am already an active component of the Housing Delivery Board. We have our own TAP board, Targeted Accommodation Programme for development of extra care housing and supported housing for adults with vulnerability and with need, and we have members of the housing team that actually come along to that board. So I have a very good level of integration already. I think this is probably, from my point of view, particularly key for partners who don't have that link in at the minute. I think that's what you're throwing the door open for here, Rob. I'm thinking particularly NHS partners, the police we've mentioned here and things like that. I mean, I suppose the offer from my side, although I have very good links in, I think we could enrich and contribute to a wider discussion with NHS partners, with the police and things like that as well. So I'd be happy to put resources into that. But I think the real decision here is, and we talked about a forum which is a subgroup of the Health and Wellbeing Board, I think we probably do need a bigger focus of it across the board. We'll come in on that, but some of us already have very good links in anyway and are able to influence housing policy and strategy. So I think people probably need to reflect on where they stand right now and whether they think they have that voice or not in terms of an active output from this discussion that can then have some tangible impact. So.
I think that's a really well made point, Neil. And again, to try and make this real for you all in the table, because this is taking you perhaps into territories that you're not used to working in. I'll give you an example, okay? When I talk about your input, I'm talking about detail of design and need, which is a more strategic question. And the thing I see it playing out most frequently is, let's take the example, the need for new children's accommodation for children in care. Okay, right. Collectively, as a room, we will all say, yes, that's really important. Okay. But when you come down to individual decisions, you get thrown at you by affected communities. Well, it'll cause crime, or it's not needed, which is a strategic question, or yes, it's needed, but it ought to go somewhere else. Okay. And for all these health questions, It's about how do we capture the intelligence in the room to make informed decisions. Because sometimes it won't be the right location for something that's, you know, desirable. So it's how we get that and not then lose track of the fact that I think it's a particularly good example in terms of children in care accommodation, because there's the perception of crime, etc., that is not borne out by any form of statistical analysis. But we don't automatically set ourselves up to have that informed debate, because informed debate is what we need on this. Because the last thing I'll say, is I'm in danger of preaching on this a bit, because it's a real thing I'll close my heart. The real secret behind all of this, and this takes us back to those problems back in the 19th century, is that we know lots of these issues and why they're important, but we underweight them in making decisions. And Colin started off by saying, yes, in the past we've been chasing the numbers on housing. What this really is a request to do is to place the appropriate weight on health in when we're making decisions. Okay, and what we're saying is, how do we best do that? We need to do it, and this is an open door. So, yeah.
Okay, my time management head is kicking in a little bit here. So what we're going to do is go around the people who've put their hands up, and then we'll do a little bit of a summing up session, I think, at that point. So we've got Abby, then Jeff, and I think primary care perhaps need to have a word, and then Jill. Okay.
Thanks very much, Chair. Great report, and really welcome the opportunities for that Healthy Housing Forum, because actually I think that's what you're talking about, is about that informed debate. Certainly from a CAB head on around energy and fuel poverty, we would love to feed in around kind of, you know, what some of the problems that we're facing and how we kind of preempt them, but also from wider VCS perspective. I'm sure we'd be able, through Thriving Together, to get some really informed community organisations and groups who actually can speak to some of those, because I think what you're talking about is some of the unintended consequences of doing things, trying to do things the right way, isn't it? And so, yeah, I've just wanted to really put that out there, that we would love to be part of that and help in any way possible. Thanks.
I was just, when Rob talked about having an exemplar so that other landlords, social landlords, could follow us. I think that's a really great idea, and that's something I've been trying to do when I was involved with Advance. The problem always came up that if you make something an exemplar, you make it the way you want it to be, it becomes unaffordable. That if you put everything on the house that you think you want to make it a really good place to live, the cost of it goes up and up and up. And that's an issue that I think we have to cope with. The other thing I think we need to have a real look at is, again, when we build houses on a village or a town, we don't really, to me, seem to think very much about the infrastructure of that town and what the effect of more housing will have on it. The absolute perfect example is in Amble. Amble has a severe shortage of doctors. They have a real problem with people getting appointments, and we keep building houses. We're currently building 150 houses right at this very minute. There's another 500 houses to come. We know that the doctors, or we're told the doctors, cannot get people to actually come to work there. And you can see some highway problems coming up as well. So we need to have a greater discussion, a greater involvement of the people who really make things happen when you build houses. It's no good just talking about planning and isolation, which I know is exactly what you're not saying. But we must get the NHS involved. We must get our highways people involved. The schools are okay, they're taken care of. But it's a thing that we're not very good at, I think, and is where I think we can really do something better than we've been doing.
Okay, thank you. And that segues perfectly into Hilary, who's sitting on the end from a primary care perspective.
Yes, thank you for that. We would really welcome the opportunity to be involved. I think for so long, primary care, and I include dentists in that, have reacted to people moving in and its additionality. And we need to think move further up and say, actually, what is needed for this community going forward and plan it. It's very reactive at the moment, and we just need to change that narrative a bit.
Thank you. And Jill?
Thanks, Chair. I love this report. I think it's a real example of progress that we're making in Northumberland in relation to walking the walk that we had just last month around the refresh of the Joint Health and Wellbeing Strategy. This is straight away into the deep dive of so what are we going to do about that? I think the complexity comes in that this isn't easy at all, but this doesn't happen everywhere either. I've worked in a number of local authorities where the relationships aren't there between public health and housing, so I think it's to be commended that there is the will and the want and the desire as much as the evidence base to prove what we want to do is of value to us. We've talked a lot about design principles and development, but as you mentioned, we are a large social housing provider as well. So I think something for the Healthy Housing Forum is about the now in all of this as well. I'm thinking about if people have vulnerabilities, whether that be mental health, whether that be criminality or anything like that. It's about how do we work with our residents to make sure that their housing isn't a compounding issue in relation to their health and well-being. So I think that Healthy Housing Forum will be a broader conversation beyond just new developments, I would hope. And I suppose on that last point, hopefully we will hold this work to account in the board. But when you mention around a health and housing conference towards the end of the year, a request bearing in mind the tackling inequalities work that we have and the Institute of Health Equity coming on board, this could be the next baton that we hand over to shine the light on housing and health through tackling inequalities, which would probably bring it forward to about the October time. And I think if that would work, I think joining that up as a tackling inequality showcase alongside health and housing would be brilliant.
Thank you. And Chloe?
Shiri.
Sorry, nearly.
The other part of the duo. Sorry, it took us a bit of time just to think about what you were saying. From a secondary mental health perspective, I think we absolutely need a seat round the table. I guess I'm kind of reflecting on the issues that we see within our community services, and then with the number of admissions that we see into our acute admission wards, for example, where housing and social situations are broke down to the point where somebody has had a really significant mental health relapse. Similarly, on the back end of that, the implications around really lengthy admissions because we're unable to discharge because housing just simply isn't suitable for some of our patients. So what we then engage in is some really lengthy retrofitting into accommodations, either privately owned or with the council. So I don't know who's best to sit on that, but I guess from a mental health perspective, absolute commitment to attend any forums that are set up. Thank you.
Rob, would you like a final word?
Point that Jeff made, okay. And I'll touch on your point about hospital discharges, okay. We build, well, not we, collectively society builds just over 1,600 new homes in the county each year. Okay, right. Everyone, at some point in their life, will have mobility problems. At the same time, we offer an adaptation service for people with particular requirements. And I have seen examples of public sector housing that have had an adaptation put into it, a new tenant, it taken out, a new 3 times on the same property. Okay. In the same way, I have seen social housing built that's been built so cheaply, this was in Sheffield, that needed to be rebuilt 3 times in a 25-year period. In other words, built, 14 years later rebuilt, 25 years later rebuilt again. Okay. The cost, we need to see, I think, in a true wider sense, okay, in terms of, because otherwise, the risk is that housing building profit margins are being made in part by passporting the cost onto the NHS. I'm not saying that this should be a complete, Stalinist, approach to this, but we need to have a proper informed conversation about what actually the responsibilities on new house builders are. Okay. In terms of infrastructure, as well, this is another one, and GP surgery and primary care, this is a classic area where we need to be better joined up. I agree with that, okay. We can include the requirements for contributions towards primary care, but often we see schemes, I can think of schemes in the county where X number of new houses built, we negotiated land and a financial contribution for a GP surgery to be built, and we couldn't get one, even though we had a GP surgery nearby who wanted to expand. But because that was an independent business, effectively, and its relationship with the NHS world of stakeholders made it a very complex process to get any decision made. So anything where we can say up front, this is what we need, we can deliver it. Jeff made also a very good point, is it works for education. It tends to work for education because there's a very well tried and tested formula where you build X houses and statistics tells you, therefore you need, that will have an impact of X number of school places in year X, Y and Z. And we get the land and the capital to build new schools out of that. Okay. For some of these other issues, it isn't as clear because it's such a multivariant issue. Okay, so this is why I think the entire world of the Healthy Housing Forum approach and hearing your voices is really important. And that's like the central message of this is how do we do that rather than just saying, yes, we all agree it's a nice thing to do. Okay? Thank you.
Thank you. You're not making my life easy this morning. I'm trying to come up with some specifics on those answers. We've certainly had a definite show of interest from members to say this is important, this is something we want to hear more about and we want to be involved. What I'm thinking is those members that do wish to be more proactive in that, let Leslie know, let's compile a list. I don't want us to have to commit people to regular meetings or contributing, but I think there's a line of communication and an ability to contribute and a responsibility from Rob and the team to put things out there to say, this is where we've got to, we're now looking for opinion, or how do you want to do that? So I think that's answering number one. Number two, I think it's absolutely important that we have a health impact assessment or some way of looking at these things. That comes down to resources, and and I'm looking to Jill to say, from her perspective, does that work and how would we do it and how often? And I think that's, you could either say now or we can do that offline at some point. But I think there's a commitment there, I would say.
There is a commitment there, absolutely, but it would be a case of screening in relation to capacity, absolutely.
Absolutely. And then the thing about how do we become exemplary in this, that's about how we relate to each other, what systems we put in place to make sure we're doing this together. I think the Northumberland Partnership work and all of that work that goes with the inequalities will probably just bring this quite close to the top of the pile, and then we can let everybody know what we're doing. Okay? Thank you very much, everybody. Thank you very much. That was a really interesting discussion. Thank you. Okay, so item... Absolutely. Absolutely. Yeah, thank you. So shift in your seat for a second, make yourself comfortable. Item 5 is the Northumberland Health Protection Assurance and Development Partnership. Veronica is going to introduce that one, and then I think it's John to speak. Thank you.
I'll make this fairly brief, but we'll just have a comment on the previous one before Rob leaves, so he may not hear me anyway, with a sort of background in the dim and distant past in social history. I'd never before put public health and housing together, so you can learn something every day. Thank you, Rob. This report is about health protection assurance and the development of a partnership. So health protection is actually a key part of public health. It's about preventing or reducing the harm caused by infectious diseases and about minimising the health impacts of any environmental hazards. Sorry, I've got the sniffles. There's a broad range of, communicable diseases that are transmitted to people. but we also unfortunately know that there are people who are more prone to experience adverse health effects following that. So this was really brought to our attention during COVID, so we're well aware of that now. But then during COVID, we also started working on strong partnership arrangements to protect the health in Northumberland. So Jill is our Director of Public Health. She's responsible for ensuring that there's an appropriate health protection arrangement in place for our residents, and this paper really describes the development of that multi-agency Northumberland partnership. So partnership will build on that strong collaborative approach. That's it really. I'm going to pass over to Jill before I start sniffling more. To John. John, I'm going to leave it to you now.
Yeah, thank you. Thanks for that introduction. As Veronica said, this paper is really about the development of a Northumberland Health Protection Assurance and Development Partnership. I wasn't proposing to get into the real detail of some of the environmental and infectious disease hazards, and I'll explain why, but we might bring that back to the board at a future date. So the purpose of the paper, as we've said, is to really provide an update on the development of this partnership, and the recommendations from the paper to the Health and Wellbeing Board are to note and comment on the development of, including the proposed scope and terms of reference which have been attached with the paper, and also to consider and comment on the proposal within the report that the Health Protection Assurance and Development Partnership presents a report annually to the Health and Wellbeing Board. To give a bit of background, just to expand on the introduction which Veronica gave, health protection is about protecting the health of individuals and communities by preventing or reducing the harm caused by communicable diseases, also known as infectious diseases. The terms are used interchangeably. There are lots of examples of those that can be respiratory infections like flu and particularly COVID, which brought a lot of the health protection world into the forefront of people's consciousness. Gastrointestinal infections, so things like norovirus, which is very common, and less common things like salmonella and other causes of food poisoning. Measles, which is quite a topical area at the minute. We haven't seen any in the northeast, but there are increases in measles and other vaccine preventable diseases throughout the country. And there are some other examples there, like meningococcal disease, which causes meningitis in children, particularly different forms of hepatitis and tuberculosis. They're examples of some of the more significant infectious diseases that we'd be focused on within the UK probably. And as we said, it's also about minimising the health impact of environmental hazards, and that can include things like extreme weather, air quality, contaminated land. Air quality can be indoor and outdoor air quality. We typically associate that with very densely populated areas, but there are examples of rural inequality or rural impacts of air quality. As we've said, it's a system-wide approach, and there are some key agencies and partners within the health protection response. So Northumberland County Council, the key parts of the council or key officer functions are public protection and environmental health specifically have got actually lots of enforcement powers and a lot of responsibilities in that area. There's obviously the public health team, and we have civil contingencies as well. And there are other key partners outside of the council. One of the most significant ones is the UK HSA, that's the United Kingdom Health Security Agency, North East Health Protection Team. They undertake a lot of the specialist health protection functions on behalf of local authorities. And that's really important that they undertake those specialist roles on behalf of us. So some of those tasks aren't undertaken by local authorities, they're undertaken by our partners. And importantly, we've got NHS providers, both primary and secondary care, and also NHS commissioners. And I think everybody will recognise themselves sat around the Health and Wellbeing Board as key partners. And there have been some key settings. These are not the only settings, but they're important ones. So particularly healthcare settings, care homes and domiciliary care settings, educational settings, including schools, early years. Rob mentioned children's residential care settings, and prisons as well. We have a big prison in Northumberland which has got a substantial population. And in addition to those kind of key settings, it also affects individuals. So each and every one of us, as we'll know through COVID and flu, has some contribution to health protection functions and health protection in terms of our behaviours and actions. And as Veronica mentioned, there are inequalities associated with health protection. This was really brought to the forefront of our consciousness in COVID. I think certainly people who were heavily involved within health protection were aware of this prior to that, but it's been brought into all of our thoughts. We know that in terms of the 4 domains of inequalities, there are impacts of health protection which are felt disproportionately, and I've put some examples in there. So, for example, we know that there are lower vaccination uptake rates associated with areas of social and economic disadvantage. There's higher rates of things like hepatitis B and C in people who use drugs, those who are in contact with the criminal justice system, so people who are in prison or frequently in contact with them. We know that poorer air quality is associated, or it's more frequently experienced by those who live in more disadvantaged areas. Quite pertinent to the last presentation, we know that people who live in poor housing may be more susceptible to some of the impacts of adverse indoor air quality, and we've heard recently about the prominent cases of mould in poor quality housing. Things like higher rates of sexually transmitted infections in some groups and lower vaccination uptake in some groups as well. And some of those people that experience multiple types of problem, they may also, well, those things will cluster together. So people with socio-economic disadvantage and in inclusion groups may experience more than one of those impacts. As we've said, Northumberland County Council has a number of enforcement roles and powers in relation to public health and control of disease. Some of those are exercised through and held by the public protection team. But importantly, with the transfer of public health to local authorities, Director of Public Health has a statutory responsibility for ensuring that there is a strong partnership approach and ensuring assurance that there are appropriate arrangements in place to protect the health of populations within Northumberland. Going back to COVID, we developed and we were required to develop a health protection board which managed our outbreak control plan. That was in the same way that every other local authority had to do the same. Our learning from that is that we brought in a range of partners who would not normally be associated with the delivery of health protection, and they were heavily involved in that response, and we had some really strong collaborative and partnership working in Northumberland. I'm thinking particularly of the outbreak response, work that we did with certain groups of people and certain settings. I'm thinking a lot of time that Abby and I spent together in different meetings. And prevention, there was a lot of work which was done with businesses and a lot of work which was done with the Integrated Care Board, or the CCG as it was at the time, and primary care to really target our COVID and flu vaccinations. So there's a lot of really strong learning which came out of COVID. We didn't previously have a health protection board within Northumberland because a lot of those partnership arrangements and a lot of that work happens anyway, and it's delivered really effectively by other partners. But we recognised in the Health Protection Board for COVID that there was an opportunity going forwards. So following the resolution or the removal of the COVID measures, as a partnership or as a board, we thought there was some real value in maintaining some of that really close working and delivering or developing a health protection partnership assurance board going forwards. We brought key stakeholders together and had some development sessions and developed the terms of reference which are attached to this report. What we did feel was really important was about the purpose, that this would be a strategic partnership really to support the Director of Public Health statutory oversight and assurance role, but go further than that to really have some added value and to provide assurance to the Health and Wellbeing Board, to provide a link between the Health and Wellbeing Board and partners with that specific focus around health protection, to look carefully at what information we have. There's a lot of routinely provided information, but there are limitations within it. I think you've heard over the past several meetings a lot about limitations in nationally produced data, that it hides the inequalities and variation within Northumberland, and we probably don't need to go over that in a lot more detail now. And we thought there was an opportunity to really identify and agree development. So that's the so what question of what do we do with the information and the analysis of that information. So the added value is really overcoming limitations with routine data, exploring and sharing information at a local level, which is specific to Northumberland, and really importantly, understanding those inequalities in relation to health protection, which I don't think hand on heart we really fully understand. We know that there will be inequalities, but we don't understand the extent and who the affected people are. And then importantly, identifying what we might do to help reduce those inequalities. In terms of scope, this is within the terms of reference. I've touched on prevention and control of communicable diseases. We've got the key partners on that Health Protection Assurance Board, including internal partners from Northumberland County Council. The next bullet point was health and social care associated infections in community settings. Jim Brown brought a paper to the board last year about the community infection prevention and control strategy, and that was an area of significant learning around COVID, really what can be done within the care setting, so in care homes and domiciliary care, to really support infection prevention and control and minimise the impacts of health protection associated diseases. We decided as a group of partners that we wouldn't look at healthcare associated infections associated with acute settings, so hospital settings. There are extensive and robust scrutiny of healthcare associated infections in the Mental Health Trust and within Northumbria Healthcare Trust, which are undertaken through the ICB. We looked at environmental hazards and emergency preparedness and response, and I'll touch on those. In terms of emergency preparedness, resilience and response, we have a civil contingencies team who are responsible for developing a pandemic preparedness plan for the council and the county, and adverse hot weather plans or adverse weather plans, which includes hot weather and cold weather. The Health Protection Partnership provides an opportunity to provide some partnership oversight and input into that planning, and also link into other work streams, so particularly around communities first. And immunisation and cancer and non-cancer screening, they're probably the things that we know most about. Cancer and non-cancer screening is a bit of a pragmatic decision to bring it into the Health Protection Assurance Board. Just touching on immunisation, we know it's one of the most effective protective measures. Overall, uptake in Northumberland is good, but we know that we're below optimal levels for some vaccinations, and we know that there is some variation, but we don't have the data to support that and to be able as yet to identify the actions that we need to take within Northumberland to address those inequalities. And as I said, we've got the key partners within that board to help us to do that. Screening, in terms of the range of non-cancer screening and cancer screening, wouldn't typically be considered to be health protection, but we have the key partners in that board, and also Jill has oversight of that as Director of Public Health. So we took the pragmatic decision to, in the absence of another forum which could look at screening, to actually bring that into the Health Protection Assurance Board. We may review that later if other groups develop. In terms of the partnership arrangements, said we've got the broad partnership, including all of the key statutory partners and internal partners. Our proposal and our meeting schedule is to have bi-monthly face-to-face meetings to provide that strategic oversight of local arrangements, identifying good practice and areas for development, and provides the opportunity to liaise with operational partners to identify and oversee development. I think that's a key point, that this will be a strategic partnership. It won't be necessarily implementing the changes, but we've got the key stakeholders who are able to link with provider organisations. And hopefully we wouldn't need to do this, but by having that partnership in place, it would provide the core membership for a multi-agency health protection group at county level if one was required. So if we had to stand up a pandemic response, it wouldn't necessarily be that board, but we've got a forum to bring people together, and we've got those existing arrangements within that partnership. So in terms of recommendations, that the Health and Wellbeing Board is invited to really note and comment about the development of this partnership, and any comments on the proposed terms of reference would be really welcome, and also comment on the proposals around governance arrangements, and particularly whether the Health and Wellbeing Board would welcome our annual report from that partnership. So I'll finish there. Thank you.
Thanks, John. For me, this feels like we should be just pushing against an open door. And I think we're already doing much of this, but this is a formal way of just saying, are we signed up to this way of working? Are we going to commit to this? It shouldn't really just be a ticking a box exercise. It's how do we do that value added element to it in partnership. And in terms of an annual report, really we're holding ourselves to account on whether we're doing that value added stuff. Derry had her hand up first, and then I'll come to Jill.
Thank you. Yes, get in first. Yeah, thank you for that, John. I think that was absolutely very clear about the direction of travel and based on the learning from the pandemic. And I suppose one of the issues for us about the learning from the pandemic was the role of family and unpaid carers. And I think that's something that I'd like to see very much weaved into this response, because I think as a population group, we found sometimes they were there and sometimes they weren't considered. And I think if you look at some of the knock-on effects of keeping that group of people well and healthy and able to do what they need to do, they are really important. So I would like to see how the role of carers is reflected in this, and actually as you know, obviously as one of the partners. And I think there's knock-on effects, because one of the things that we did learn clearly from the pandemic was what happens if carers are not seen as part of the system and are kept out of the care homes and the acute settings, and the effect that that has on mental health as well as people's lives. So I would say absolutely welcome this, but can we make sure that the role of paid and family carers is really woven into it?
Thanks. I'm really grateful to John for his leadership on this work. It hasn't been undertaken lightly, because what we didn't want is just another meeting for the sake of it. So when there was that close down from a COVID Health Protection Board respect, it was a case of, well, so what? And that was a really meaty conversation over a number of development sessions to create the board. And it is about assurance, but again, that could be quite a tick box exercise. And to do that term justice, it's about looking at the inequality inequalities. So absolutely, Derry, picking up on your point, when we established ourselves as a new function, we want to screen everything through those 4 domains, because at a superficial level, the data, as John refers to, could look okay. We pretty much do well at Northumberland level on lots of things, but the devil is in the detail when we drill down. And if the data's missing, that's when we need the soft intelligence about, well, what can we do about this? For example, the second immunisation for MMR is always a drop. What is it that is triggering that? How can we work with family hubs to generate that? So it's bringing it to life. It's bringing the human element to this, so it doesn't feel such a perfunctory board. Even, albeit strategic, we are the drivers of that change to be implemented at frontline. So once again, thanks, John, for all of the work. And it's great that the partners have bought into this. We've only had one formal meeting, haven't we, since the development session, so it's a relatively new group, but that annual report that we want to bring in here will show our state of the nation at county of Northumberland level in relation to the communicable diseases and environmental hazards and such like. We just thought this was more about the governance today.
I'm going to take the nods in the room as an acceptance of the proposal, and that largely we accept the scope in terms of reference.
Just may I add how grateful the County Council is for the work that the partners do with us. I think we set a really good example of joint working and being stronger together. So on behalf of the County Council, I do want to thank all the partners who have worked so hard together. It really is appreciated.
Thank you very much. I'm sorry I didn't spot you. Okay, so we'll accept that. Thank you very much, John. And the idea of an annual report, I think we're agreeing that that will come. I think when I come to the forward plan, there is a thought around how we start moving things and just know when things are coming. So I'll come back to that later in the meeting. Thank you. Moving us on. So we're now coming to item 6 on the agenda, notification of pharmacy closures in Blythe. It's a recurrent theme, is pharmacy closures. I think it's the 3rd time we've had Pam and Anne come to talk to us about this. It reflects some of the issues to do with national contracts for pharmacies. We've got some members of the ICB here to support us in this discussion as well. So I'll pass to you, Anne. And where's Pam? It's Anne that's presenting. Anne's going to present, but I'm here for any questions or any follow-up. Perfect. Okay. Thank you.
Have been hit by various pharmacy closures, and we have chosen not to declare that it has got to critical point until this particular paper. Blythe as a community is already disadvantaged, and due to a set of circumstances, we used to have 5 Boots branches in and around Blythe. They sold off one just after the pandemic, which they had given notice that they were going to close, and it has been bought by an individual who used to work as a Boots manager in that branch. Because of the financial situation and the pharmacy contract, Boots has undertaken a national programme of amalgamating branches where they've had branches very close together, and we have seen examples of that in Alnwick, Hexham, Morpeth. So you can see that there's been, over the last several years, a drive by Boots to cut their expenditure on duplication. They have already amalgamated all their branches that they thought they could do so, and have started on a national closure programme, and they had identified 300 branches nationally which they were going to close. This is known about nationally, and can I just say, I shouldn't be advertising ITV, but there is a programme on ITV tonight about 8:30 on pharmacy closures, and they are saying that 8 pharmacies per week are closing across the country. So if you want more background information about what is happening nationally. Maybe this programme can do for pharmacies what it's done for the post office. We can but wait and see. Of the pharmacies left in Blythe, the board is asked to consider whether we still have sufficient pharmacies to provide all the services we now need from pharmacies, remembering that the government is pushing on the primary care agenda to go to your local pharmacy first before you go and bother the doctor. If we are pushing more pharmacy services, we need to make sure we've got a robust infrastructure of community pharmacies able to support their local communities. So the board is asking, we're asking the board, are there still sufficient pharmacies in Blythe to meet the needs of the residents? Remembering that it's more than just doing prescriptions. And also, as part of that, agree to update the pharmacy needs assessment, which was written in October 2022, and declare a gap in services. And I'll give a bit of explanation as to why I think we now have a gap in the Newsham area of Blythe. And also ask that the task and finish group that the Overview and Scrutiny Committee set up use their expertise in this area to consider options for provision of pharmacy services if we don't get any applications in when we declare that we have a gap in services. And I don't know if we will have any applications. I think the key issues are that of the 8 pharmacies which previously served the population of Blythe, 2 will have closed within 3 months of each other. And additionally, the 100-hour pharmacy has reduced its hours to 72 hours per week. So we have lost the equivalent, not just of the 2 pharmacies, but 2.5 pharmacies, if you take it that a pharmacy contract is normally for 40-odd hours a week. I actually went round all the pharmacies back in the summer to see how they would cope with the well, at that time, with the 1 pharmacy closing at the health centre. 2 of the pharmacies said they had capacity to take on more work. One was a very keen young pharmacist who had bought out the Lloyd's branch in the town centre and was really keen to expand on the services that were offered and was really looking forward to the challenge of taking on more work. Also went to the pharmacy in Briardale Road, which used to be a Boots pharmacy, and the pharmacist there was also keen to take on some work, but said that there was no way they could take on all of what had been displaced by closure of 2 pharmacies. When we look at the medical services in Blythe, they are concentrated on the health centre, with most medical services being provided through the 2 surgeries in the town centre. Although one of the medical practices does have a branch surgery out at Newsham, which seems to serve a community of extra deprivation, if you can have extra deprivation in an already deprived area, where housing is not of the highest quality. There are populations within there which have moved in more recently, where English is not the first language, and you wonder about how they are going to be able to access health services if it means a trip into the centre of Blythe. The community of Newsham seems to think it is of itself not as part of Blythe Central, but as its own individual community. We did do a map of where the buses go and where the surgeries are, and I've been assured by the surgery and the chief pharmacist within working with those practices, that Newsom, whilst it provides a lot of chronic disease management services, it is also where those people who can't get into the centre of Blythe go to for medical services. And the pharmacy there also provided a service that was really centred around that population. And I think it's important to realise that a lot of healthcare now takes place over the phone, so pharmacy services situated in deprived communities are even more important than they perhaps have been in the past. We looked at the prescription data, and the loss of the 2 pharmacies has displaced approximately 20,000 prescriptions per month. And that is more than any of the pharmacies, apart from one, are doing per month. It's an awful lot to take up. It's an awful lot to expect people to change to using internet pharmacies to provide them. This is a community that's probably not that IT literate or have access to IT easily within their homes, and getting deliveries sorted out might not be that easy for them. We also looked at the other services that these pharmacies provided, and flu vaccinations were given quite widely within the community as well as within the GP surgeries. We have lost potentially from next year quite a significant number of people who may not, because it's not quite so easy, access flu vaccines. And we looked also at the other services these pharmacies offered, and are concerned that for supervised opiates, a high percentage of those that access this service got their opiates from the Newsom pharmacy. All I can say is, looking at the numbers that are now involved, if this had hit pre-COVID, there were a huge number more patients who were getting supervised opiates. So we're not dealing with quite as big a problem, but these are probably the more problematic cases that are still on supervised opiates. The other thing that the likes of Boots Management would tell you is that they are very efficient and run a hub and spoke approach. Therefore, prescriptions that go into their branches within Blythe are sent off to a factory where they're dispensed and then sent back to the local branch for distribution. But on talking to the pharmacy managers in some of the branches, it sounds wonderful. It sounds as if the workload is being taken away and done in a central hub very efficiently. But when the prescriptions come back, the robot has rejected several big classes of drugs that it won't touch. It won't touch anything that has to be stored in a fridge. It won't touch anything that's a controlled drug. It won't touch quite a lot of the liquid medications. So when the patient comes to collect their prescription, instead of it being a nice, smooth operation, it's sitting there on the shelf waiting for the patient to come in. The pharmacist then has to intervene, find what's missing, and then go and dispense that. So it's not as slick and straightforward as we've been led to believe. Because of the nature of the population of Newsom, we are recommending that any new pharmacy application for the Blythe area is centred on that population, and that it provides services 6 days a week. Now, I'm not saying it has to be open Saturday afternoon, but there has to be the capacity on a Saturday morning to be able to go and access pharmacy services for that portion of the population who work and would find it more readily accessible. And we'd also want any provider of pharmacy services to be prepared to do opiate supervision, again, so that it can provide services to that population. So I am recommending that you agree that pharmacy services still need to be provided to that local community from a local community hub, and that we do a statement to say that we have a gap in services. The other statement just acknowledges the changes in ownership, which keeps our master document correct, but it also shows the huge turnover by multiples. We haven't noticed many independents selling up. It's the multiples that are contracting and selling off individual stores to people who are willing to take on the pharmacy service. Thank you.
Thank you. Pamela and Ken have come from the ICB, especially to listen and contribute. So what I'm going to do is just ask if you could introduce yourselves in terms of just explain what your role is at an ICB level in terms of these types of issues, and then give any comment for us, if that's okay.
Yeah. Thank you. Thanks, Graham. So I'm Pamela Phelps. I'm the Deputy Director of Primary Care, and that covers general medical pharmacy, dentistry and optometry for the ICB. And from the 1st of April, the ICB for North East North Cumbria and nationally took on the delegation of pharmacy. So it was quite a surprise when we had the opportunity to do the deeper dive on pharmacy. We are in unprecedented times with pharmacy provision, and that in light of the ICB taking the delegation from April, it is a challenge. However, what I do want to do is just thank Anne and Pam, because the considerable amount of work that they've done on the gap analysis and the impact assessment to this, it is considerable, and it's an exemplar example really of how we should be looking at this. And I think it's the impact on the services and the communities in particular. The relationship with the Health and Wellbeing Boards on pharmacy needs assessments in the past has been with NHS England as a contracting function. I think the opportunity we've got as an ICB is to really bring in that understanding of, from a commissioning perspective, the holistic needs of the populations that are served by these services. So we're working collaboratively with Northumberland, who are helping us with a case study as to how we do this much more robustly and strategically across the whole of North East North Cumbria. So that's a bit of context about where we are and where we sit. I think the other thing is about how we take the recommendations and the findings from Health and Wellbeing Board and Pharmacy Needs Assessments, and how we work with you together to identify opportunities for service provision moving forward. I think one area for me to highlight is when we are seeing the gaps in provision, and as Anne articulated, we've got multinationals who are consolidating, we've got supermarkets where there's location of pharmacies making decisions to remove them, we've got national contract changes where they're reducing hours and the ability to reduce hours. All of these things add up. But I think for me there's an opportunity here with the Health and Wellbeing Board and with health partnerships to really understand at a more local level what we do for those patients with end-of-life care needs who would have had access to medicines where we've lost potentially part of the system. We've got patients from mental health services who access drugs. So there's an impact then on the services, not just the pharmacy in the community. There's an impact to continue to manage those patients with their care and their needs. And I think that opens up an opportunity for wider discussion about the impact of the pharmacy closures. So we're here today, you know, as a support and advisory capacity, but also working in collaboration. And we would support whatever decisions the Health and Wellbeing Board make to convert that into some opportunities for future provision in the Blythe and any other areas we identify.
Would anybody else like to comment? Neil?
Yeah, just a quick one from my side in terms of the ask of Health and Wellbeing Board members, myself included here, in terms of making a decision. I mean, I completely trust the judgment of the people who've been involved in this assessment, but it's just a comment on the report itself, in that I'm not sure, for me individually, it has enough information for me to make that decision. I mean, it does say, which sounds unequivocal, that Newsham has a high proportion of elderly people and high levels of multiple deprivation, but it doesn't include any comparative stats. And I guess my worry is just in affirming the decision that Newsham still needs a pharmacy, which I'm absolutely sure it does, based on professional judgment. Does that then open up the arena that there are actually a lot of other areas in Northumberland with a similar level of high numbers of elderly people, a similar high level of deprivation, and why not us would be the next thing that comes along as a challenge. Additionally, if we look at Blythe as a whole, outwith of Newsham, and coping with the 20,000 additional prescriptions that won't be picked up by the two pharmacies, again, I don't know the level of growth in terms of the use of the internet, in terms of prescriptions. I don't know whether if GPs started to have a first conversation with people about using the internet before they went to a pharmacy, would that accelerate that level of growth? I guess I'm just trying to be balanced as a member in my view, but I'm not doubting for 1 second the level of professionalism that's gone into the representation that's been made to us. It's just the report itself doesn't have a wider evidence base for me necessarily to be able to corroborate that.
Thanks. I think that's a really good challenge. Pam's got her hand up at the back. And I'm in agreement with you in that it's almost that we're taking an expert's advice, but in terms of declaring that there is a gap, are we sufficiently informed to make that? So Pam.
Thank you, Chair. I was just going to say that this is kind of a supplement to the whole P&A. So the whole P&A came in 2022 in October, and that did include all of that data. So it does look at comparisons. I suppose what this is a response to the things that have happened since October 2022. So all of that data is there and is available to anybody. It's on the website and it's available to anybody. But that's why this is specifically focused on this area.
And for clarity in my mind, I would assume that if a pharmacy was considering closure, they would consider selling their business to see if anybody else was willing to purchase that business. So there's an assumption here that that process has already been gone through and these are applying to close. And then I'm suspecting that once they are closed, for a new pharmacy application to enable a new pharmacy to open, we have to have declared a gap to allow that from a commissioning perspective.
Yes.
Yeah. So are we all clear in our minds that that's what we're discussing here? So if we didn't declare a gap and the pharmacy closes, no other pharmacies can open in that area. Yeah? Jill.
So I think we've got a real opportunity with overview and scrutiny concern in relation to this and the fact that they want to undertake a deep dive, and it's for us to be able to support the scope of what that looks like. So going back to Pamela's comments around that holistic nature of pharmacy and that specific population cohort. So I think it is it's for us as professional experts to advise and guide the totality of what that overview and scrutiny consideration looks like, because we want it to add value to the narrative ultimately, don't we? So going back to your point, Pam, we have the overarching pharmaceutical needs assessment. We know what our market is. We now are declaring a gap, but what is that gap needs to be filled by going forward is the review ultimately, is my perspective.
I think the figures that we've presented show that there is enough work there to support another pharmacy. But the demographics of the Newsham area means that we wouldn't want another pharmacy in the town centre per se. It would be much more useful if it was located within an area of multiple deprivation. And if we don't specify the area, we would have to, or our colleagues at the ICB would more or less be duty bound to accept any application within the town centre.
Hilary.
I'd like to ask a question. Obviously, Boots are closing because, in terms of their business model, it's not financially viable. What happens if nobody comes forward and puts an application in?
I think that is where we work with the ICB to try to provide something that is attractive enough to make somebody apply to open a pharmacy there. And that there are tools that the ICB could use in the form of different sorts of pharmacy contracts, but it would be much nicer and simpler for everyone if we knew what we were getting and it was a standard contract. That would be the ideal. Now, Boots, because they have got such a big presence in Blythe, I don't know, I didn't hear of it going up for sale, unlike other ones that they have sold. I think they just assumed, like the health centre pharmacy, that they could push all the business into the other pharmacies. And I think the staff at Newsham are really, really upset at what has happened. So I don't know that there isn't a market. I suspect that the price they were asking for, if they did put it up for sale, was too high. But they sold off the one at Seaton Sluice. That there are people there willing to buy pharmacies still. And if they don't have to buy the goodwill, it may be that we can attract somebody if they know that it is a gap that we have declared. So I'm not without hope, but we'll just need to keep our fingers crossed. And a lot will depend on what the view is of any changes to the pharmacy contract and whether it is going to be more financially viable. But there is a financially viable business there. It's just not what Boots want. It's not got a big enough profit margin for what they want.
Okay, thank you. Pamela, you had your hand up?
Yeah, and I think what Anne's articulated there is the options we've got, and we have got opportunities. That nationally, the pharmacy has been seen as the other main provider of primary access for patients for care. I think you're quite right to ask the question. We still have to have a plan B or a plan C, where if there is no interest in the areas we potentially identify gaps over and above the needs assessment, it comes back to the point that Jill and I have mentioned about how do we therefore support those patients in their health and care needs, and that's when it's a wider conversation for all health partners. So when we have the pharmacy needs assessment meeting for Northumberland, we sit with Health Watch around the table, we have the lead pharmacist Northumbria Trust around the table. So it's not just about we need a pharmacy, we can't get a pharmacy, therefore job's done. It's about how do we open the opportunity of that collaborative working to identify how we support those communities and those individuals who need access to the services. And it is becoming more and more not just about prescribing and the dispensing of medicines. I think the urinary tract infection service now, where patients are attending pharmacy, we've got pharmacists being trained in prescribing, coming out of the... So there is opportunities coming. We have to make that attractive. We have to be innovative. But we do need a plan B, I absolutely agree.
I've got Wendy first and then Chris at the back.
Thank you, Chair. Anne, I'm not familiar with, is it Newsham or Newsham?
I don't know. I'm not from these parts.
Right, okay. Well, I'm not familiar with Newsham. But where do people go in Newsham? Where is their GP practice?
In the centre of town, on the whole. Although there is the branch surgery about 500 yards from the pharmacy.
Right. So in theory, if they need a GP, they do have to go into town to see the GP.
Well, what I have been told is that increasingly telephone appointments, FaceTime appointments, that they're not all face-to-face appointments in the GP surgery. So having a health hub within the community is also important, so that people can access treatments for minor conditions without having to go into the town centre.
Yes.
That's why we also put on bus routes, so that we could work out, could patients easily access on one bus the services within the town centre. And for a lot of those patients, yes, they could. It's certainly easier than the closest pharmacy, but only if you've got wings. Because I drove between the Newsham Road pharmacy and the one in Briardale Road, which is allegedly the closest, but it's only the closest as the crow flies. I wouldn't like to send an elderly person between the two pharmacies. I would be saying to them, if you've got a bus pass, hop on the bus and go into town. A, you've got a choice of pharmacies, and B, it's much easier than that half an hour walk around various ginnels, as we've heard today.
I think this is really where community comes into things, doesn't it?
Yeah.
You know, if someone is elderly and there's a close community, and I would think Newsham has one, I think someone would be willing to say, I'll pick up your prescription for you. I think that's something that could be looked at.
Thank you. I'm just going to go back to Derry's point as well. The vast number of people at home are supported by carers, and it's not the patient themselves that's picking up the repeats, it's the carers, and that's a whole different way of thinking about how the community works. Okay, so Chris and then Jill.
Yeah, thank you. So I'm Chris Jenkins, I'm from Northumbria Healthcare. I think just a couple of points really quickly, Graham. I think the first point I'd just like to make is it sounds like it's in everybody's interest, not least the patients, to make sure that they've got health facilities and access to health as close to home as possible. And the pharmacies, I think somebody's pointed out before, is a route that we're trying to get more people to access before they come to primary care, before they come to a urgent treatment centre or ED. So I guess that offer there's from Northumbria in terms of, I don't know what any very limiting steps are to, it sounds like we've got 2 local independent providers there. If there's any help that's needed from ourselves, I guess it's in our interest, it's in everybody's interest to offer that help and see what we can do if that's required and appropriate. The second point is that if, like we've heard, that people and populations are accessing pharmacies for things other than prescriptions, is if those pharmacies are taken away, what's the impact of that, and how we're going to measure that impact, or how we're measuring that impact, and how we're going to measure that impact to say, you know, has it made an impact? How great is that impact? Where's that population then going to access healthcare, and what's the impact on other services that's caused by closure of a pharmacy in a particular area? So I think it's probably important to measure that, isn't it?
Good points, thank you. And Jill?
It semi-leads on from that point about it feels like we've heard a lot around professional opinion here, which is right and proper. We're a professional audience, but there is a community voice piece in this as well. And I'm wondering, back to the scope of the overview and scrutiny work to be undertaken, because it could well call in all professionals, say, what do you think, what do you think? But there it has to be a piece, and I'm looking at Derry, but also family hubs and Neil around adult social care services. You've got that vulnerability list, haven't you? You know who people are and potentially affected. So that conversation needs to take place in duality to the professional opinion, because there could be, Wendy, the people who are prepared to pick up, but there could also be people incredibly isolated and vulnerable as an account, but we need to look at that. And then it's the different cohorts impacted, such as methadone users and such. So I just think there's a scoping piece to do parallel to the professional voice over the next couple of months whilst we declare the gap.
Cherie.
Thank you. Just in response to your point, there is a piece of work that's currently being undertaken by Northumberland Recovery Partnership to hear the voice of the OST users that are having to go to alternative pharmacies, because it has been a huge concern for us. Fortunately, we've been able to contingency plan for OST users to be able to seek support from alternative pharmacies, but it's not always that simple as jumping on a bus for some of these OST users. It's significantly more complex than that. And we are worried that it means that there will be a breakdown in people being feeling able to be compliant with the prescription. So there's a piece of work that's happening that we'll be able to feed back into around that service user voice that suffer from many, many inequalities. Thank you.
I was just going to make the point that people have mentioned that it's often carers that collect prescriptions and do other small tasks. If they're having to go and wait for a bus and go into town, it takes up an awful lot of time and potentially money from what was a convenient service just down the road. So it will have knock-on effects to a wider group of people if they're going to have to take time to go into town to pick up a prescription rather than collecting it locally.
Okay, thanks. I'm going to bring us to a close. Firstly, I'm going to go back to the question that Neil raised about the risk of declaring a gap, and to see if Neil has now heard enough, or does the room feel sufficiently that we can declare a gap on this case?
I mean, for me personally, I trust the professional opinion that we've got in here, which I think I said at the start of my piece, it was more about how the reports are presented going forward. It would just be good to have a fuller data set to be able to understand that. Graham,
Okay,
so thank you.
That's good. So I think we have an agreement in the room that there is a gap. Yeah.
Yeah.
And I think we've heard a lot really from people to say that whoever is convening the task and finish group needs to draw on the knowledge and expertise in the room. It doesn't declare in here, but I'm assuming that a task and finish group will report back to the scrutiny committee. Yeah. But we will hear something about that in due course.
Absolutely, Chair, and we'll work with Chris Agnes, who's the OSC officer, to do the scoping, and we'll bring the scoping back here, the terms of reference for that as well, for information.
Thank you. Thank you very much, Anne. Yeah. Okay. I just need to go back to my agenda at the top. So give me a second. So that brings us to item 7, the forward plan. That needs me to page back down to the bottom on my computer to the forward plan. There we are. So next month's meeting, we have community transport and health needs assessment. So that's taking us further along the road of the building blocks of a good life, healthy life, the new phrase, okay? So that's another theme that we're exploring there. And I think those elements, we're actually having really useful discussions about that, and I think it is leading to further work outside of here. And then we're starting to focus on families as well. So we've got 2 items much more about families and the family hubs. And there are other pieces of presentations going on to the GP Collaborative and the System Transformation Board. So in the coming few months, there's a bit more of a focus in our system around how we are working on that. And Harrogate are also going to be at the next meeting too. As far as the forward plan goes, it needs a bit of a refresh, to be perfectly honest. I think what I'm going to suggest is Jill and Paul and I and Leslie have a separate meeting between now and the next meeting, and we just reorganise, because some of the names on the forward plan are no longer accurate, and we need to just have a think about the annual reports and whether there is a way now of planning out which month the annual reports are going to be coming in, so that we can make sure that the meetings all run smoothly and sort of segue. And if there is an annual report due, people are given notice, lots of time, and we know when it's going to come, and that will allow us to keep track of everything. Okay? Does anybody wish to make a comment on that? And obviously, if there were things that you think should be in the forward plan and aren't there, we are more than happy to receive ideas. But don't do too many, otherwise Leslie will have a headache. Okay? Glenn?
Could I just ask, when we're looking at the forward plan, to see if there's any chance that we could hold a meeting, not in County Hall, but in the where our partners might be working from, if they would like to host a meeting. I know there are difficulties around recording and so on, but I would have thought it would be really helpful to get to know some of the people a little bit better that we see briefly once every 2 months, just because we're working so closely. I would certainly welcome that, and if it's possible, I would really hope that we might do that.
Thank you. Yeah, I'm sure we'll take that on board and have a think about how we could do that. Absolutely. Okay. Anything else on forward plan? I believe we have no items of any of the business, and just from a formal perspective, I'm just making sure I haven't missed anything. No, the next case was urgent business, and we have none. The date of the next meeting is Thursday, the 8th of February at 10 a.m. in County Hall. Thank you very much, everybody. Have a good day.